Hi, good evening, everyone. So I'm the host of today's session, Meet the Specialist Internal Medicine with Dr. Tan Guo Jeng. So Dr. Tan will be joining us in a while. And yeah, so this is a very good initiative from Medical Society, especially million thanks to our Academic and Career Planning Bureau. So they plan this as to raise the relevancy of medical society to medical students. So this will be a series of talk, and the first session will be about internal medicine. So Dr. Tan will be joining us in a moment. I have shared the so if you have any inquiries regarding internal medicine or any questions to Dr. Tan, kindly submit your questions via Slido. So yeah. So this is for internal medicine. I just realized there are some questions for us via Google Doc, and I have copied and pasted the question into Slido. So yeah, I'm the host of today, and I'm Gan, the current president of Medical Society. So Dr. Tan will be our first invited speaker to talk on internal medicine. So this series of talk we will be focusing on a lot of specialties. Like the first one will be internal medicine, and the second one is upcoming soon. So Dr. Tan is here, and I would like to add him into the stream. Dr. Tan, are you ready? So I would like to add Dr. Tan into the session. So initially we would like to conduct this series. Initially, we would like to conduct this series of talk as a forum way in the Cube, like perhaps every Wednesday afternoon. But due to this COVID outbreak, so we changed it into the form of virtual platform for us to share each specialty and how should we enter the specialty. It takes some time for Dr. Yeah, Dr. Tan, can you hear me? Hi, Doctor. I think there is some connection. There is some connectivity issue. Hi, Dr. Tan. Dr. Tan, can you hear me?
Hello.
Yeah, hi. Hi, Doctor, can you hear me? Doctor, I think your mic is muted.
No, I can't hear you.
Okay, a moment, yes. And
Hello, can you hear me?
yes, I can hear you, Doctor.
Okay, good. You can hear me, but I can't hear anyone.
Yeah, actually this is like they are just commenting. You only can hear me at for this session. Just a moment here. There's some technical error.
Okay, can you hear me?
Yeah, I can hear you, doctor. But now we have.
Yeah, I'm using my laptop.
I'm using my laptop.
Okay, now everything is nice. Okay, the view is nice and we can start our session now. Is it okay, doctor?
Sure.
Okay, so we have Dr. Tan, our specialist in internal medicine from PPUM here today to share with us what's the journey towards internal medicine and what issue and how he make sure himself is entered the specialty. So Dr. Tan graduated from Penang Medical College. Am I right, doctor? Just some
Yes.
background research. So yeah, you have done your HO and MO ship in Hospital Tunku Jaffa.
I did my housemanship in Kuala Terengganu, so I spent 2 years on the East Coast in Kuala Terengganu. Can I take it from here? Then after that, you ask me the questions.
Yeah, sure.
Okay. So I did my housemanship in Kuala Terengganu. I spent actually 3 years in Kuala Terengganu. My first year as a MO, I was actually in pathology. And then after that, I was in Hospital Tuanku Jaffa in Seremban. That's when I did the final part of my MRCP. And then I finished. I did my gazettement in Hospital Klang. And after 3 years I actually completed my gazettement. But in the meantime, I actually wanted to apply for PhD to do some research and get a paper of that. So applied to UM, and then UM offered me a job, and then I came in here as a general medicine specialist. Okay.
Okay, so yeah, some very basic question. Why doctors study medicine or pursue medicine in the very first place? Like perhaps we have some first year here as to motivate them first before we further go into internal medicine.
Oh, why did I want to become a doctor? Okay. I wanted corny answer lah. I wanted to help people. Okay, so I told myself, okay, what's the most effective way? There is engineering, build toilets for people. There is also engineering. You can get clean sanitation, but then again, physics and maths wasn't my favorite subject. So biology actually is actually very interesting. I like dealing with life things and all that sort of thing. And then, medicine, you get to talk to people. Medicine, you get to walk around, you meet different people. So actually, for me, medicine is a bit like it's much nicer lah. Engineering, you just face the computer, do maths, draw the design, go build something. You do meet people, but you meet contractors lah. But medicine, you get to meet more people, sort of thing. So I thought, hey, medicine may be a good maybe a good. Unfortunately, I was ignorant lah. I didn't have any doctors in my family to tell me the cold harsh truth. But once you are like first year, second year, already like too late to turn back. People, if you quit now, people say, "Oh, you cannot finish. That's why lah. You quit, not because I had better offer or something like that."
Okay, yeah. So I very agree with Doctor in this. It's like medicine is also a combination of art and science. In the art part, we talk to patients. We really enjoy those moments. So yeah, and what is the reasons behind that motivate doctor to do internal medicine?
You know what? I didn't choose internal medicine. Internal medicine chose me. We have to understand that sometimes in life, a lot of us have big dreams. You know, when I was in university, I wanted to be an ONG specialist. Actually, I love ONG. I want to be an ONG specialist. Yeah. Uh, I'll explain that later. Excitement later. Yeah, I want to be an ONG specialist. Surprise, surprise, surprise! I actually like delivering babies. I like to do Leopold maneuver and all that stuff. I think it's really fun. You know, you guess the weight of the baby, 3.2 kilos, and then baby come out 3.2 kilo. Oh yes, see, I'm so accurate. You know, but then when I did my housemanship, that's why I don't have too big dreams. Once you thought, oh, I want to be an ONG specialist, then when you do your housemanship, you are treated like literally you treated so badly. I told myself, look, I am not going back to the labor room unless my wife is delivering or something like that. I do not foresee I want to work with these people. So that's why I decided to do something else. Then when I was a house officer, I actually enjoyed peds very much. So I wanted to be a pediatrician. Then went to the head of department and said, look, Dato, I really like pediatrics. I want to do pediatrics. Take me in as your medical officer. After I one look at me, you know what? You were my husband for 3-4 months. I get to assess you, I see your personality. I think you throw the babies out the window. You got a very bad temper. You know what? You should do adult medicine. So that's why I went on the path of adult medicine. Because I respect the input and also the opinion of my HOD or Pete. So I would have loved that he took me, but he look at me and say, look lah, let's be honest lah, you got very bad tempered, and then you do beats, you will throw the babies out lah, So consider doing adult medicine. That's why I went on the path of doing adult medicine. So actually, most people they already decided in medical school that they're going to be cardiologists. Okay, before they even they
Yes,
start their
yes.
housemanship career, done their part one, part two. For me, I didn't even start my part one until I'm like, after my housemanship. So actually, yeah, I'm a bit late to the scene, and I didn't even know what is what. How to get into a sub. I have no idea. You have to go and step up to the subspecialty bosses if you want to go and do a sub. So that I didn't know all these things. I just like, oh, do adult medicine now. Okay, lor, take paper only lor. Boss say what, go and follow only lah. But then I you don't know the politics and all that sort of things lah. Yeah. So that's how I didn't choose internal medicine. Internal medicine chose me.
Okay, understood, doctor. Yeah. So just now, doctor also explained it. It's quite some number of medical students usually will dream of like doing some popular specialty like cardiology, surgery, and orthopedic. But doctor has explained to us. So regarding the journey towards internal medicine, so at the moment, few questions up from our colleagues. So what are the pathway available for us to do internal medicine at the moment?
Internal medicine in Malaysia. Okay,
Yes.
so now you got two pathways. You have the so basically what you need to do is finish your 2 years housemanship, and then if they iron out the issue with the what you call the MO contract, because by right contract MOs cannot get HLP to go for the Masters of Medicine. So they haven't. You see, the problem is every time in Malaysia, Kementerian Kesihatan Malaysia, they will only cross the bridge when they reach the bridge. They won't like, oh, we are approaching a bridge in 3 kilometers. Let's get ready to cross the bridge and all that sort of thing. They wouldn't. They reach there. Oh, we have a bridge. What should we do now? Oh, the bridge cannot do this. The bridge cannot do that. Oh, then only they will decide. Okay. Now that you all finish your housemanship and finish your contract already. Oh, maybe we change. Then only then they will change the criteria because it's all written in their SOP. The Kementerian there. Oh, you must be what you call permanent staff. Only you can get HLP. But now, if everyone is on contract, how to get HLP then? Then you must change. Either they change the SOP to say that, oh, what you call non-contract staff can receive HLP, or they must what you call, they must change and say that, oh, look, if you are you are contract, you also can receive a HLP and also continue training. So they either have to do either one of these, but they haven't done it anyway. We are waiting for it. So, but anyway, that's beside the point. So we have Masters of Medicine and we have the MRCP pathway. MRCP pathway is the British paper. You go and take a paper. Okay, you sit for all three parts. You pass it, you can become a what you call internal medicine specialist. But everything is study on your own. So I was in Seremban. We only have rheumatology. We have endocrinology. We have nephrology. We didn't really have an ID physician because the ID physician actually belongs to IMU. So if it belongs to IMU, when IMU say we are doing exams, then the whole month the ID physician will not be around. So I didn't really have a lot of subspecialty training rotations. But you sit for the paper already. I haven't done cardiology in my whole life. Then, you finish already the paper, you done your 3 years. Okay, you start the exam, you go to Clang. Oh, okay, please interpret all the ECGs now. So actually, the training is very scattered. Now, KKM said that, we have a parallel pathway. Anyone who's sitting for MRCP must register with them. But even with the parallel pathway, whatever we see right now, they don't even have a set rotation. That, because your hospital don't have cardiology, will send you to a hospital with cardiology. It's still the same, where you just work 3 years, and as long as you got your 3 years, you do your 18 months gazettement, and then you come out as a fully registered specialist, and then that's it. Okay. This is just for the primary, just become a general physician. Then you have your Masters of Medicine. Masters of Medicine, the pathway is you work 3 years as an MO, you collect your SKT points. SKT is your appraisal, yearly appraisal. So you score more than 85% every year, then for 3 years in a row, then you can apply for the HLP. HLP is basically the KKM. You see, KKM, Ministry of Education, both also serve the rakyat of Malaysia. But KKM will say, my budget is for my people. Ministry of Education, my budget is for my people. So KKM wants MOE to train people. So what you go? Okay, you know what? I don't want to release these people unless I really have to. So, but MOE is say, the salary when the masters from KKM, the person come to MOE, come to UM to study Masters of Medicine, KKM must pay their salary. So then they have this HLP is basically to pay your salary, KKM salary, while you're in MOE, because you're serving the MOE hospital. They don't care you're serving the Rakyat Malaysia. To them, in their eyes, you're serving MOE hospital. Okay, so we want the MOH will say, unless we really have to, we won't send. So they only have a limited number of Hadia Latihan one. All right. So then, if let's say your year, everyone took already, so don't have to wait for the next year, so you wait another year. But the good thing about internal medicine is everyone knows being a physician sucks because doctor will refer everything to you, surgical refer everything to you, everyone will push all their patients to you. Okay, no glamour whatsoever, to be honest, actually. So every year there's 100 spots, 100 HLPs for internal medicine. They'll send about 30 to UM, 30 to UKM, something like that, then 20 to USM, all that something. So every year there's 100 spots. Every year only 70 or 80 people apply for it. There's 20 spots that no one fill up. But the last 1 or 2 years, because now we got this glut of house officers, they're all becoming MOs, they're finishing MOship, they are subspecialty. So they want to get into a specialty. So now even the Masters of Medicine is difficult. But Masters of Medicine is structured. Okay, it's structured. In fact, the exams to pass the Masters of Medicine is actually more difficult than MRCP, to be honest. Okay, because they cover everything. And then some of the things are very arcane one. They don't test it in places anymore, but then they still test it in Masters of Medicine. So you still have a lot of things that we would like to edit out, but we can't. So actually, in actual fact, people who pass their master's exam, a lot of times for me, they're actually much more impressive than the people who pass their MRCP. But MRCP, you can actually hack the exam. So you do your question bank, okay, and then after that, for your first 2 parts, you just finish your question bank, okay, 2 times like that. You should be all right. Third part, you get someone to teach you. We teach you what to say, how to dress, how to stand, how to talk to the examiner, what kind of questions they ask, how to answer the questions, can pass one very easily. Whereas Masters of Medicine, sometimes you got some of these old fogies, they don't like your face, they fail you already, because Masters, they don't have standardization in their marking. That's one thing. So up to my mood lah. I want to pass everybody, I pass. I want to fail everybody, I fail everybody. And in MRCP, the basis, you have to justify why you give this candidate that score. Why you fail that candidate? Well, how come? Because they have two examiners. So one will give if you, let's say one give a pass, you give a fail. Why do you fail the candidate? Then you have to explain, oh, the candidate didn't do this. And if the senior examiner, no, I actually don't agree. I think he did quite well in this. Then you have to pass. So it's actually like geared towards passing. Whereas the masters and all, because there's always one very, very senior person and one very, very junior person. Then the junior person like ikut saja lah the old folk, the old fella what he wants to do. So that's the maybe I go off topic already lah. Those are pros and cons lah. I would say MRCP is easier to pass, but masters they give you all the rotations. It's very structured. Okay, and if you come to, I cannot speak for University Kebangsaan Malaysia and all the other university, but if you come and do your Masters of Medicine in University Malaya, I can assure you, we will give you very good training. Okay, and in medicine, even though there's structure in Masters of Medicine, okay, but you don't expect it to be like in your Masters of Engineering, Masters of Mathematics and all that sort of thing. You still have to go and look for your own teachers, still have to go and look for the consultants or the specialists like, Dr. Tan, can you do showcase with us? All that sort of thing. So there's still a lot of initiative, but you don't need it as much as you are in an MRCP.
Okay, yeah, understood, Doctor. Doctor, just to clarify, so MRCP pathway is under KKM, but Master of Medicine is under.
It's called a parallel pathway. Both are under Ministry of Health. Both are recognized by the Ministry of Health. But okay, one you can only do Masters of Medicine in a university setting. Okay, whereas MRCP is in your own pace, in your own time. You sit for it. So some people they like in 1 year they finish all the papers, and then after that, I actually have 2-3 years of service. Okay, I start the exam, but actually they are not prepared to be a specialist. Maybe 5 years ago, 10 years ago, because you see one person sees so much more patients, so they have the relevant experience. But now you talk about the young specialists of 2020. Okay, let's be honest lah. Let's be honest. A lot of the some of them are really, really good. They are the really, really smart ones. But to be honest, there's quite a number that, I think it's the personal attitude. If let's say you're always like, okay, I'm not that smart. Actually, you keep on thinking you're not that smart. Actually, I'm not very smart. I should learn more. I should study more. Be humble and always ask people and then try to learn as much from everyone else. Even though if you think you know a lot, but you still like, I think I better, keep quiet, be humble. And then people can see that. People can see your effort and you will improve. But if you let's say, I passed my MRCP, I'm the smartest in the world. Everybody don't know anything. Only I know everything. Those are the people that are. It's like oh my god, that fella is like what? Better double check all his work. You cannot be sure he managed all the patients properly. Yeah.
Okay, Doctor, just to clarify, for MRCP, actually we need to pay for it. But for Master of Medicine, instead of paying for the master, actually we did get payment as we are actually serving the university hospital. Am I right? Or actually you need to enroll, you need to somehow pay for the tuition fee.
Okay, so MRCP you pay on your own, but Masters of Medicine, that's why this Hadiah Latihan Persekutuan come in. So technically, the Hadiah Latihan Persekutuan is Ministry of Health paying your salary for your time in Ministry of Education. And then the fees is technically, because it's between the ministry, we are all serving the Rakyat Malaysia. So technically, the fees also is paid by Ministry of Health. That's why you must finish it within the 4.5 years. If you don't finish within the 4.5 years, okay, then then you actually had to go back to KKM, and that gets difficult because Masters of Medicine, first year you have written and clinical examination paper. Second year you don't have an exam. Third year again another written paper, and also you have an OSCE with some short some modified essay questions. And then for the fourth year, you're supposed to do a research project and present thesis and all. So MRCP actually don't have this final component of a thesis. So actually, people who have MRCP background, they don't know very much about research. They don't. Okay lah, unless you read on your own. Again, this one is people who gone for. There are people who gone for masters who have gone through the thesis project and still know nothing about research because they didn't read up. They don't bother. They're not interested to learn about it. But as a general rule, because everyone is forced to do it, so everyone has some research experience and everyone has an idea what is research. Whereas the MRCP fella, unless he's very hardworking, he reads up on his own, he's not gonna have any research experience. Yeah.
Yeah, it's all about initiative.
Yes, initiative and the individual. That's why. Okay, so that's why in Malaysia there's this MRCP versus masters, masters versus MRCP. Oh, you're lousy. You're stupid. You cannot pass your MRCP. There's two masters. Oh, you MRCP fellows don't have rotation. You all don't know how to manage anything. So actually, we must be of the attitude that look, we are all serving the rakyat of Malaysia. It's not the government paying me a salary. It's the rakyat through the taxes paying me the salary. So I want to serve the rakyat of Malaysia, and I want to serve to the best of my ability. So whether you did your masters or you did an MRCP, if you say, oh look, this is just the beginning. I've still got so much more to learn. You continually upgrade yourself, do your medical education, do your research. Then if you're of the humble attitude, then you will be a very good physician. Okay, and then I better teach my MOs, I better teach my housemen because these are the people that are gonna go out to the clinic kesihatan and all. And then we teach so that now maybe this level of quality of care can only be found in the city, but maybe another 10 years, 15 years, in the clinic kesihatan, everybody who's hypertensive and young will get an investigation for young hypertension. So I think that is very important. So I think we do not lose the main focus and the main goal. Okay, it's like MRCP and no. It's a means to an end. What is the end? Serving the rakyat Malaysia, giving the best quality of care. Just an aside, I have actually one of my students. He went for an attachment in actually it's a cardiology summer school in the largest cardiology center in South America, and they have 300 cardiologists in that one center. 300. That is the number of cardiologists in the whole country of Malaysia. And to them, even though they have 300 cardiologists in that one center, they say that, we actually don't have enough cardiologists. We are looking to train more and want to train more so that, everyone would be within 1 hour of a cardiology center. Everyone will get a primary PCI if they need it. Now, that's their goal. Now, even in UM, we don't, after office hours at all, you may not get a primary PCI because there's just not enough staff. And there's just not enough people. Imagine one guy has to do 24-hour on call, come in at any time. There's only right now there's only 2 or 3 trainees. So if they're gonna rotate among themselves 10 calls a month non-stop, everyone's gonna die. So actually we need to expand our numbers. Okay, UM has 400 lecturers. We think we are so great. Oh, we have 400 lecturers. Wow, la la la. And Oxford, Cambridge, Harvard had 7,000, 8,000 lecturer, staff on the faculty, not including all the other adjuncts and all that sort of thing. So if you really want to move up the ranks and compete with people, we really must consider expanding our numbers. Yeah.
The MRCP versus master program is just like for us STPM versus metric. So however, we still pledge to serve our patients or the rakyat. And doctor, I would like to ask, brain drain is real, and do overseas recognize our master of medicine?
Okay, so if you want to actually, if let's say I know of people who they want to go overseas, and I'll give them advice. Should you take PLAB? No, the PLAB costs so much money, and then you don't want to go to work for UK. Actually, the last 2-3 years, UK has been actually taking post MRCP people. So if let's say you pass your MRCP within the last 2-3 years, you can actually apply for a job in UK, and they will look at your job, and then they'll look at your experience that you didn't do some of the rotations. So you join, do some of the rotations, you complete the rotations, then you go into a subspecialty training. It's usually something that they lack, so that they don't have. But I have heard of people getting endocrinology, cardiology is one of the popular ones. I've not heard of people getting cardiology and gastroenterology, but the rest, I heard of Malaysians, they after their MRCP, they go there and they get the training spot and they complete and they get their what we call CCST, the Certificate of Completion of Specialty Training. So yeah, so Masters of Medicine is recognized with the caveat that you also have a MRCP. So if let's say you did a Masters of Medicine in University Malaya, and then at the same time, because there are so many MRCP coaches in University Malaya, so you also take your MRCP on the side. So basically, you need an MRCP if you want to go to the UK. UK would be actually right now the one with the best. They would be the one that is the most easy to brain drain through. Singapore also, if you have they don't recognize Masters of Medicine, but they recognize your MRCP, so they have your MRCP. But again, Singaporeans are like that. They don't really want you. They don't really love you. They just want, because their own Singaporeans are going to Australia, New Zealand, and the UK. So at first they thought, oh, I have a cardiology trainee. Suddenly that cardiology trainee got a better option, get a better offer in the UK, went off to UK. So, oh no, now I have, the consultant has to do the cardiology trainee work. Nah, I don't want to do that. So they're gonna start looking for a Malaysian to go and fill up the spot. So if you're lucky, you might get what you want, but most of the time it's what they need. So if you are not choosy about your subspecialty, you can get anything you want. Yeah, but if let's say you're like die hard, I want to do nephrology, and then if they have a spot, then good for you. If not, they will say, you want to do palliative. Nothing against palliative. I love the palliative care physicians, but you want to do palliative care? No, none of the Singaporeans want to do it because it's not glamorous. Then it's like, okay, no choice. That kind of thing. So actually, you know what they say lah. What hujan emas di negara orang lain, hujan batu di negara sendiri. Actually, the people who stayed actually had better opportunities than the ones who went overseas, because some of them, they went to Singapore, they thought Singapore, promised them 1,001 things. Oh, it's going to be, they're going to give you this. And suddenly it's like, our Nanyang grads are graduating. Oh, sorry, we need to save the space for our Nanyang grads. Or it's like, that year, maybe a lot of the Singaporeans didn't get a job in the UK and Australia. So, oh no, we are not going overseas. We are staying back in Singapore. So then they will say, okay, all the spots are filled. Do you want to do general practice? We'll give you general practice. And then they will shove you all into general practice. And yeah, I'm sure if some of the yes, of course, you have heard stories of your seniors who completed everything very, very fast. I'm sure you also hear horror stories of your seniors who got all their papers, but because we don't have an empty slot for you, here, take general practice. So that's how things are lah. Basically, yeah, people only want something that they can get from you. No one is gonna nicely give you, we want a cardiologist. Here's a cardiology. Nobody's gonna do that. Everyone is like, actually, we don't have someone in the Western Highlands of Scotland. Would you like to take up that post there? You won't be the one in the cardiology training in the Western Lothian.
So, Doctor, regarding Master of Medicine, what is the criteria of us getting HLP? Is like recommendation from your bosses, or actually doing MRCP? Perhaps some of our seniors can complete their part 1 or part 2 in this 1 year of waiting, and they can just say, because of I'm having these 2 paper, part 1 and part 2, I have a better chances to enter master.
Okay, be honest, your MRCP has no bearing on the thing. It's your SKT. Okay, but SKT, sometimes it depends on your hospital where you are. Like some bosses, even if you are very, very good, he gives you 99%. If even you are the laziest MO that he has ever worked with, because he knows like there are some bosses, they are just naturally nice people. So you are the laziest MO ever on the planet of the earth, and you always disappear. But you say like, if I give you 80%, you will lose, you'll not get your HLP, you will not get your masters. So he will say like, you know what, I don't really like your work, but I give you 85.10%. So you get the 85%. Okay, there are some bosses, you are the best in the world, you are the smartest, can answer all the questions, but you know what, I don't like your face lah. I'll give you 84.9%. It's true. So what happens is, and then it's all based on your SKT. It's supposed to be fairer, lah. Whether you have a part one, part two doesn't matter, but all based on your SKTs, and then they'll take you for an interview. But in the old days, anyone who wants to become a physician will just take only. But now, because there are more competition, the interview, everyone will say nice things, lah. I will serve, lah. I will not sleep, lah. I will, do on calls every day, lah. That's what they all say during the interviews, lah. But after, when they come in, it's all a different story, lah. It's just like before you get married, it's like buy you roses every day, buy you chocolates every day. But after, get married, it's like con you already, sign the dotted line, no more roses, no more chocolates. It's that kind of thing, lah. But the thing, to enter a Masters of Medicine, the most important is actually your SKT. And as I was alluding to earlier, some bosses are terrible, some bosses are, super nice people. So no matter how, so imagine you are the lazy fellow with a very, very good boss, you get 85.1%. You are the really, really good fellow with a very, very crappy boss, you get 84.9%. Guess who gets to get the HLP and the HLP is the crappy fella. Because why? On paper, he has the better score. So it's very uneven throughout the country. So even if there are people who are doing housemanship in different departments, even in the same department, different bosses, it's like, it's terrible. So it's actually not really, really fair. And then, as one of the specialists in every year the new master student coming. This year we don't have because of COVID, but every year when you have new master students, they come in, then you're like, oh no, it's like, oh, that person, it's like, oh, that person is coming in. Oh, then you suddenly relieved because your friends will tell you, hey, I got this lousy fella that's coming over. I don't know how he got placed. Like, and you see the fellas, you get palpitations seeing the guy walking into your ward. It's like, yeah, these are the kind of things that happen.
Okay. So, doctor, is there any other program that we can enter medicine after MRCP and also master, or that is the only pathway that we can do internal medicine?
There's also the MRCP. the member of the Royal College of Physicians Ireland, is actually a separate paper from MRCP UK, because Ireland is a different country from the UK, so they have their own exams, but it's also for the same format: 2 written paper, one practical or OSCE paper. Whereas your Masters of Medicine, you actually have 2 written papers and you have 2 clinical exams. So actually you have 4 exams, and you have to hand in the thesis. So if you ask me, the Masters of Medicine actually has more rigorous training. Yeah. So, and then they have to, and then you have to rotate through all the subspecialties. Each subspecialty will write a report about you. So, we have people that come in, exit after 4 years, they are same as they before, never learn anything. But those who are willing to learn, they are humble. If you see them in first year, they are such a different person from when they are 4th year. And when I see those students, then we know, hey, we done a good job. We have this person who is not so good has become very, very good after 4 years with us. And I think that is the credit to not just one person, but to all the staff in the Faculty of Medicine. So, yeah. If you go to the KKM website, they will give you a list of other papers. There's also some other papers. So what happens is a lot of them is they are studying in the US or they're in Australia. So they pass the papers there and then they come back to the country. So all those papers are also recognized. But in this country, most of the people are MRCP UK. So if let's say you need someone to guide you on how to take the exam, where to take the exam, and because there are so many people taking MRCP UK, MRCP actually has a center in Malaysia. Whereas if let's say you want to take the Australian paper, you have to fly to Australia and take the paper, because I don't think there are enough people in this country to justify opening a center to take. So, but there's a whole list that KKM recognized. So it's actually more for the people who study overseas, completed training overseas, and they want to come back and then check whether their name, their specialty certificate is on that list or not.
Yeah. Okay. So, doctor, we have a question for you. Doctor, can you explain what is the gazettement that you have done in Klang Hospital before this?
Okay, so basically, because the MRCP is so short, so we had there are actually known cases of people completing their MRCP when they were housemanship. I think in USM in 2010 or 2011, there was a house officer from USM, like a USM grad, smart fella. So he completed his MRCP within his housemanship. So automatically, he started his gazettement right after his housemanship. Then I think in 2014 there was a UM guy who completed his MRCP during his housemanship. So basically, gazettement is supposed to be your tempo percubaan sebagai seorang pakar. So if 8 years ago, you straight away they just throw you in and you are the specialist in charge of the ward. Please take care of the ward. You are the final authority. If you say discharge, we discharge this patient, and then you are in charge of this ward. You are the boss in this ward. So that was 8 years ago. But nowadays, because there are so many more people, so back then, by right, the original idea of the 18 months gazettement was 12 months as a registrar, as a senior registrar, as a senior MO, and 6 months as a specialist in training lah. So you are playing specialist lah. You are pretending you are a specialist, and then you see the patients by yourself, and then if you miss something, then that's it. There's no one else hired that is gonna double check your work. So you do that for 6 months. But 8 years ago, 10 years ago, there were so few people. So it's like the moment you start your gazettement is we'll throw you in as the what you call trainee specialist already. Everything, yes, you are in charge. Anything happens, you take responsibility. Yeah. So that was 10 years ago. But over the last few years, because there are more people now, so now your 12 months is actually a real MO period, registrar period, where you are the senior medical officer in the ward. You do a lot of the stuff, but you still have a specialist that is on top of you that will come and double check your work at the end of the rounds. So that is what gazettement means lah. Of course, gazettement 8 years ago means a totally different thing from gazettement now. But gazettement is the period before they officially recognize you as a specialist. Then after when you complete your 18 months gazettement, your boss will sign your logbook, say, okay, you did quite a lot of work, saw a lot of patients. None of the patients have died because you made some silly error, and then they'll write a report and letter about you. He did everything okay. I got no complaints. He didn't go and commit a crime or something, steal the patient's handphone, while doing rounds. So very good person. So then they'll send your letter to the National Specialist Register, and then they'll register you as a specialist in internal medicine. And after you are registered with your NSR, then you can apply for your specialty training. So the current rules is you completed your gazettement, you can straight apply. Back then there's a waiting list, so they say you can only apply after 1 year. But nowadays they are more liberal with the training spots, so the waiting list has more or less disappeared, except for I think maybe dermatology or cardiology. So what happens is you apply for your sub, 6 months later, 1 year later, they'll say, okay, we have a spot. You go in and start your subspecialty training, and then you complete 3 years of subspecialty training. They have certain subspecialties don't have exit. Cardiology doesn't have exit exam. Infectious disease doesn't have a exit exam. So cardiology only has a logbook. You do more than 400 angiograms. Okay, excellent. You have done your required number. You get to register as a cardiologist in the National Specialist Register. Yeah, so that's the thing lah.
Understood, doctor. So, like university hospital, will we receive those MRCP students coming for their gazettement, as we do have our own master program already?
I think master's program is different. So when you talk about gazettement, so master students also have gazettement, but their gazettement is only 6 months. So when they finish their master's of medicine, they hand in their thesis, they get their master's of medicine scroll, so that they are considered graduate from the master's of medicine program. Then they go back to the KKM hospital they came from, or whichever needs an internal medicine specialist, and then they'll be posted there. 6 months they'll be doing their gazettement, so they'll be a trainee specialist for that 6 months. Gazettement period for MRCP is 18 months, 12 months as a registrar, and then 6 months as a specialist. So actually the 6 months is the same for MRCP and masters. But because MRCP did not have the final year of doing the thesis, so you are supposed to have 12 months as a registrar in whichever hospital you are in. So masters of medicine, they complete, they do 6 months, and then after they apply. So what you want to get at is probably, does University Malaya take in subspecialty trainees? yes, University Malaysia do take subspecialty trainees for the subs. In fact, right now, every sub, because when the people, a lot of them in UM, they complete, then what they do, they want to go to private, then they leave. So we need their replacement. But there were some issues about gazettement and all, because in technically under the rules, there's written somewhere in some arcane thing that only the Director General of the Ministry of Health can gazette someone. So that means if you say I completed my gazettement, you actually get a letter from the DG signing and says that this person has completed his gazettement. Then you take this letter, you send it to NSR, then only you get registered with the NSR. That's one of the paperwork you have to do. So you must get this paper from DG. Whereas if you don't do your gazettement in, let's say you finish your masters or medicine, you straight join the subspecialty training, or you are from KKM, you finish in the old days. What happens? You finish your MRCP, you straight the next day you jump to UM as a subspecialty trainee. So technically, those people don't have that letter from the DG because they didn't do their gazettement under the Ministry of Health. So there was some period of time where they didn't want to pay out their specialist allowance. So there was some negotiation. You can't blame these people because they came in before the rules were set and all that sort of thing, blah blah blah. So in the end, they got paid their specialist allowance. But subsequently, after that, University Malaysia only take those who have completed their gazettement. So if you're planning to come to UM after your MRCP, best that you complete your gazettement, then only they apply. But unfortunately, UM it's actually a lot of times, how do I put it? It's luck. It's not that you are the best of the lot. So unfortunately, people think, oh, come to UM. Oh, my lectures are the best. No lah, not really lah. Sometimes it's luck because the best candidate for that post, when he applied, they said, oh, we have no post for you because there's no money to create this post. So IGN gave him an offer. He went to IGN already, no? So subsequently, the next fella, when the guy who's occupying the post resign and go to private, then they will suddenly open up. Then they'll start, oh, where to find a replacement? Where to find a replacement? So they just grab whoever there was and bring them in. And then that's why I'm sure if I look at it, I can see quite a number of University Malaya students. I'm sure if you all if you're in clinical years, you can see that the quality of lectures is either this high or that low. Even sometimes like that also can be lecturer. That sort of thing. Yeah.
Okay, there's another question for you. So after we get our MRCP paper, we need to do 4 years of medical service to enter gazettement. So so can you elaborate on that?
Okay, so basically, like I was telling you this, that there's actually in the history of Malaysia, there are people who completed their MRCP as house officers in 2010, 2014. So the guy in 2010, he completed. So technically, if you have the MRCP, you can actually start gazettement. So the day after he finished his what you call his housemanship, the next day he started off as gazetting as a specialist. That was the rules back then. So of course, as you can see, since he had not much of medicine experience beyond that 4 months as a housemanship, he had a very steep learning curve lah. So subsequently, they changed the rules so that even if no matter how fast you pass your MRCP, you must have 3 years of experience in medical. 3 years. So you have to have 3 years of medical experience before you can start your 18 months gazettement. So I can see that they were saying after we get MRCP, you need to get 4 years of medical service. That 4 years of medical service is technically the 3 years as a medical officer, the 1 year as post MRCP. So that's the 4 years. Then only you go into your final 16 months or final 6 months. By right, only the final 6 months you can behave as a specialist. The first 12 months, actually, you have to still work as an MO. But like I said, 8 years ago, there wasn't enough people. So instead of the first 12 months as a registrar, as a MO, you were just functioning as a specialist. So you had no choice. Yeah. But of course, over the years, I passed my MRCP in 2012. That's like 8 years ago. That's like, oh my goodness, if I had a kid then, he's already in standard 2 already. So things have changed a lot since then. So now there's more people. Then they say that, okay, now you can do a registrar. You're a registrar for 12 months before you start as a trainee specialist for 6 months. Yeah, I hope it answers your question. Mm-hmm.
Yeah, So, okay, doctor, since you have mentioned regarding contract MO, so like we have served, perhaps in future we serve contract MO for perhaps 1 year, and does the 1 year consider into the 4 years of medical service, like what doctor have mentioned just now?
Mm. Sorry, I didn't get the question. Can you repeat that?
So you mentioned that we need to do 3 years of MO, and plus 1 year of post MRCP. If we were to do contract MO, since contract MO is a very new term for everyone. So if we
Yeah.
were to serve as contract MO, does it include into the 3 year of service?
Like I say, KKM does not cross the bridge until they come to it. So basically, I don't think anyone who is under this contract system, I don't think there's anyone who has passed their MRCP totally yet. I know of quite a number of them who has their Part 1 or Part 2A. So KKM is not thinking about it until they come to the bridge. Then only they decide what they want to do with contract MOs and how they're gonna go about their assignment and all that sort of thing. But so far as I know, I don't think there's any precedence and all. But once people who are under the contract MO start passing their MRCP, their paces, then they have to decide what to do. Then only they'll probably issue a few letters and have a few rules, and then all the HOD will be confused how to implement the rule, and then one hospital do it one way, another hospital do it another way. So that's what I can foresee lah. So I think we keep our eyes open next 1 year when the contract people start passing the fastest amount. I won't say smartest lah. Nowadays is you're just fast. The fastest among them will start passing, and then we see what KKM is going to do. Yeah.
Okay, noted, doctor. So there is a question from our So perhaps just briefly come out with perhaps some recommendation, as we have mentioned a lot about the difference between the pathway. But since someone is asking this question, so I think it's fair for doctor to perhaps give some recommendations.
Okay. I'm an MRCPian, but if you look at the things that have been going on for the last few years, I'm actually now very pro Masters of Medicine. So if you want, then you take Masters of Medicine actually, and I think the train you'll become a specialist and enter sub slower than the other people, but you will actually have a better grounding. Now there's two schools of thought of people there. It's like there are some people say, hey, I've become a cardiologist already, I'm an electrophysiologist. I don't have to know any. I go in private. I don't have to know anything about diabetes. I can refer to my endocrine colleague to do. Yes, yeah, you may be very good at what you do, and then you just reach the destination as soon as possible. But sometimes the interesting part is actually the journey there, and it depends on what you want, lah. Some people just want to finish it as soon as possible and go into private and start making money as soon as possible. There's I can't change everyone's attitude. It's up to the individual. But if let's say you want a more rounded masters, you get to do a thesis, about research, you get rotations and all. I would recommend. But the downside is the exams are a bit tougher and a bit not so what we call it's not so standardized. So there is some issue lah.
Okay, understood, doctor.
USMLE. Oh, if you want to go overseas, then you have to choose between USMLE, MRCP. You pass, you can actually go to the UK. So it's actually quite a good pathway if you want to go overseas. Stick to the MRCP. USMLE, they're changing the rules over and over again. So actually, nobody knows. Sometimes it's just pure luck. If let's say your parents can afford it, that you'll be unemployed for a year, and then while you're waiting for your job or get the relevant experience in the US, then I think it's okay. So actually, it's also dependent on the individual families. Yeah.
Okay, understood, doctor. So, doctor, can you share to us some interesting story in your journey, as someone is asking, what is in the interesting part in internal medicine?
What moments make you glad you did internal medicine? Okay, I can tell you a story about this guy this morning that we saw. I am in charge of the general medicine ward. In general medicine ward, basically, let's be honest, general medicine ward is actually the dumping ground. It's like if people are on call, look, if you come in chest pain, the ECG show changes. What else is it? is a acute coronary syndrome, right? Go to cardiology, come in, short of breath, fever, got a patch there. Oh, yeah, this is a pneumonia. Send patient comes in. Oh, I got vague bilateral lower limb weakness. My legs are jelly. Suddenly, I cannot walk, and then nobody knows what's going on. Okay, put this patient in general medicine ward, and they dump the patient in general medicine ward. But then, of course, when the patient reached our ward, with some careful history taking by the medical officer, and also they went through the investigation results, and they found out, hey, this patient has a hypokalemia with metabolic alkalosis, chronic, partially compensated metabolic alkalosis. And then you look further. Oh, he actually had a history of hypertension that was very difficult to control with 3 antihypertensive, and then it's like suddenly we realize, this may be some adrenal problems, and then we referred to endocrinology, and endocrinology we just saw the patient and then took over the patient, and then so we feel very satisfied that we have managed to come to a diagnosis just by careful history taking examination and just review of the investigation results. So I of course it's not something big or fantastic, but every day you just live for all these small little victories. Patient gets better, or patient has a problem that's been coming into hospital 3-4 times. Nobody has found out what's the problem, and then you just by careful history taking, you found out that actually he has a Wegener's granulomatosis. I actually picked up a Wegener's once. The poor guy is a 21-year-old boy. They diagnosed him with end-stage renal disease, put him on CAPD, but he actually comes in over and over again for shortness of breath. They label him as fluid overload, but when you see this patient, his JVP is not raised, there is no pedal edema. So actually, technically, it's not actually fluid overload. So I actually went through his investigation. He said, oh, actually, I did some investigations in Sunway in a private hospital 2 years back, before I came over to whichever hospital I was in that time. So I actually looked through and found out that he actually has C-ANCA positive. So we picked up Wegener's. Okay, and he's end stage because of the Wegener, and he's been with us for a year and nobody picked it up. So you live for small victories like that. Yeah.
So, doctor, there's another question that comes from our audience. What kind of patients that internal medicine specialists deal with?
Deal with all kinds of all the patients that cannot be solved by surgery lah. You have a fracture, you need an orthopedic surgeon. You have abdominal pain, right iliac fossa, you need a surgeon. If you are a child, you go to a pediatric. If you're pregnant, you go to ONG. The rest of them comes to medicine.
So, doctor, there's another question. Is there any more sub-specialty in internal medicine?
Sorry, what do you mean by is there any more? Can I see the question? I don't really understand the question.
Wait, the question is from our.
Oh, it's not there lah.
Yeah, it's not there.
What's the question again?
Is there any more sub-specialty in internal medicine?
Of course. Okay, are you talking about? Okay, so basically, once you became you are in internal medicine specialist, there are subspecialties you can go into. So there's the usual one, neurology, and then cardiology, respiratory medicine. Then you have gastroenterology, dermatology, and then after that you have did I say endocrinology already? Then you have nephrology, then you have infectious disease, you have hematology, you have palliative care, you have geriatric medicine. Okay, so over the years recently they restarted this thing called acute internal medicine. Basically, they just need someone to do general medicine, but they give you a fancy title so that actually you can attract more people to stay in general medicine. So because you see, not everyone will fulfill the criteria to go into cardio ward. Not everyone will fulfill. There will always be this bunch of patients that can be anything. You need 2-3 days to let the fluids come out first, then you can really get a diagnosis. Yeah. So so why didn't I specialize further? My further specialization is acute internal medicine. It's not very well known, but it's supposed to be. Of course, for me, I don't think that it's a real subspecialty. I'm specialized, but the next step is subspecialty. But subspecialty, in UM, you can't be choosy. They say we only have post for this person to do this. Then we go in and do it lah. Okay. Yeah, would I have done cardiology? Yeah, they have a post for cardiology, but then again, we just do what opportunity. Sometimes we just have to take what opportunity. So yeah, I'm specialized further. I'm specialized or subspecialized in supposed to be this acute internal medicine. Yeah, yeah. How best the brain? You see, this. I think I was mentioning about this attitude of trying to finish things as fast as possible just now. If you want the short answer is take the MRCP UK. Yeah, and then just. But unfortunately, a lot of people think the MRCP is. I will say it's easier than the masters, but it doesn't mean it's easy. So we have people that struggling part 1 3 4 times, part 2 3 4 times. Okay, so actually, if you want speed, then what's your how good are you lah? Just basically it lah. You may think you are that great, but the Royal College may not think so. So if you keep on failing the exams, then it's gonna be delayed lah. So assuming you pass all your papers all in one shot and as fast as possible, the fastest route will actually with the least delay will actually be your MRCP UK. But I think I have met really fantastic MRCP, and so I have a few of them right now in my ward. So basically, I have one of them. He's already got his part 1. He's going for his part 2. Another one is already completed his part 2A. This guy, he would have completed his MRCP before the end of his housemanship if it wasn't because of the COVID. But because of COVID, he got delayed. But he would have, I suspected he would have passed his papers during his housemanship. But what this thing common in these people, they have read through their Kuma and Clark once. Okay, they have read through, one of them even read through Kuma and Clark and Davidson's. So if let's say if you want to be fast, but you haven't read through Kuma and Clark even cover to cover even once in your life, I don't think you'll be very fast. Yeah. Yeah, like Dr. Koo here says, read Kuma and Clark, do 2 question banks. And not do 2 question bank 20%, like do 100% all the questions, 5,000 questions plus 8,000 questions, complete the whole question bank, complete 2 question bank. Dr. Koo is very interesting. He's actually one of those he's completed Kuma and Clark cover to cover once. He's completed his past test and past medicine question bank before his MRCP part 1 and part 2. Okay, I have another health officer. He's read, like I said, he's read through 60% of Harrison's, cover to cover Davidson's, cover to cover Kuma and Clark. And yeah, so which is a better, I think there's no such thing as better. All are recognized in Malaysia. And again, it's up to the individual. There are people who keep on learning. So even though they may not pass with very good scores in their MRCP, but because they continuously learn, after 5 years, they are untouchable. And there are some people who pass with very, very good scores, who finish very, very fast. But after that, they stop learning. And after that, 3 years later, you see them again. It's like, wow, you're really crappy, aren't you? Yeah. So be the kind of specialist that don't be just because finish as fast as possible. Be the kind of specialist that people want to work with lah. If the people see oh no, this guy is in my ward like oh he's always miss things one lah. His management very lousy one lah. Yeah.
So,
best way to prep yourself for MRCP, I think Dr. Koo has answered that question. Read your Kuma and Clark cover. Okay, if you're running out of time, you're really short of time, at least Kuma and Clark cover the cover and finish past test question bank. I think, if I'm not mistaken, someone asked this same question to Prof. Chan Wah Kiong. You know what Prof. Chan Wah Kiong said? Well, I think it's quite easy lah. Past part 1 wasn't that challenging. I read through Kuma and Clark twice during my housemanship. Yeah. So people ask him, hey, how you pass your part 1 and part 2 during housemanship? Oh, during my housemanship, I read through Kuma and Clark cover. So every year of his, but back then, you see, the housemanship in his time was only 1 year. So within that period of time, he actually read through Kuma and Clark. Every 6 months, he read through Kuma and Clark cover. So unless you're going to plan, if you can read Kuma and Clark cover in 6 months, then I think you will finish your MRCP very, very fast. Yeah.
So, Doctor, this is a question regarding dermatologists.
Okay.
How to do the pathway to be a dermatologist?
Okay. What kind of dermatologist you want to be? You want to be just at the end of the day, individual. You want to be the dermatologist who's just good in dermatology and nothing else, or so, but of course, it's a generalization. There are some people who took their MRCP who are actually very, very good who became dermatologists in the end, but also very, very good at everything else. Yeah, there are people like that. So this question, I don't know lah. You want speed is actually not about speed. It's all about the individual, and sometimes it's the opportunity that avails itself. Let's say you get sent to the hospital where there are no MRCP guidance. There's no one to coach you on how to examine MRCP style and all. Then it's like, oh, how? Are you gonna sit for the exam until you pass 3-4 times, costing £1,000 each for your papers? You know, sometimes you have to be realistic about your situation. So there is no such thing. And whatever I tell you now may not be applicable 1 year from now, 2 years from now, 3 years from now. Because every year the KKM is changing the rules. Like I'm saying, like 8 years, in my 8 years of passing the MRCP, they have changed from at first, you know, you straight away your gazettement is 18 months as a trainee specialist. Then next you are 12 years as a registrar. Then they maybe next year they say maybe you might have to write a thesis before you can go on to be fully registered with the NSR. So all said and done, you might end up being slower than the person who takes their masters of medicine. But dermatology is finished, become an internal medicine specialist, complete your gazettement, then you apply for a dermatology trainee. If you have MRCP UK, you may apply to UK. But if only UK have a dermatology training spot, if all the training spots are taken, they will say, we have rheumatology. Do you want rheumatology? So again, you might want, you think, well, do I want a rheumatology training spot in the UK or dermatology in Malaysia? You know, maybe by then you may change. You may work in a department with a very nasty dermatologist, and then you don't want to see another dermatology patient ever again. So I understand, because you're the students, and then you want to know more. You know, you achieve your goals and dreams. But sometimes, like I said, internal medicine didn't choose me. I didn't choose internal medicine. Internal medicine chose me. So yeah, you wouldn't know. You might end up in a spot with a very charismatic surgeon, and you might say, hey, maybe I want to become a surgeon. Maybe I want to become a plastic surgeon. So then you can deal with the skin and be in surgery. Okay, this way, the surgeons, they are, if you read your Norman Brown's, the surgical diagnosis of the diagnosis of surgical diseases, Norman Brown's has FRCS, and he's also FRCP. So there are people who actually there are surgeons in the UK that take MRCP for fun, just to show their physician colleagues that, I'm actually quite smart. I can do what you're doing, but you can't do what I'm doing. Yeah. So if you want to challenge yourself, maybe you can do a Masters of Surgery. You see, you can't do you can't do MRCS and do Masters of Medicine and do MRCS and become a surgeon. But you can do a Masters of Surgery, and in the meantime, go and sit for your MRCP on the side. And then you can be a cardiothoracic surgeon, cardiologist, neurosurgeon, neurologist. Yeah, you can, the neurosurgeon still do neuro examination, but you can challenge the neuro. If you are good enough, you can challenge the neurologist. Yeah.
So, doctor, since you mentioned about mentioning about surgery, so this question, I think, do you have any interest to pursue surgery?
Actually, at one time I did have lah. I said I want to be an ONG. ONG is actually a branch of surgery. So actually, I do like surgery a bit, but unfortunately, my experience in surgery wasn't that what you call that inspiring lah. I think the weakness about surgery is that it tends to attract a lot of people who. Are there any surgeons in this group? There are a lot. It tries to attack people who are a bit of like to, what we say in Cantonese, people who like to shine people's shoes and polish apples, because you see the surgeon, you need the surgeon to say, hey, I'm doing this special procedure. We only do it once or twice a year. Come in now to assist me, and then let you give you a chance to do all these things. So a lot of them, they'll be in the OT boss. So when I was actually the surgical junior medical officer. Yeah, I will not mention the hospital, but so I was there, and every day the other junior medical officers will be already disappeared into OT. No one does rounds for the patients. No one do the pre-op rounds. No one do the post-op rounds. No one to correct the sodium. No one to correct the potassium. So I ended up being the one who correcting all the potassium, all the sodium, and getting the patients ready for op. Okay, because the rest of my colleagues have went up there. Let's be honest, they went into the OT to suck up to the surgeons. So surgeons like to be sucked up too lah. So unless you you are those person who like to, you might not enjoy surgery as much, but some of us, it's just for the challenge, just to prove to people, I can do surgery and all that. But I didn't have I didn't have such an enjoyable time in surgery, so I ended up in internal medicine. Yeah.
So yeah, somehow since we are not doing in a so-called lecture time, and this should be somehow in an interacting section, and loving the honesty by Edra. Nah. So yeah,
Yeah.
the next question will be on. Okay. No, we have answered. And yeah. Okay.
For unsure about specialization, like I said, I think a lot of it is about the journey, and I think why not? Of course, UM tends to have all these UM legends who completed the MRCP, ASAP, and all that sort of thing. And I know sometimes I'm guilty of this myself. Hey, come on, you should do your MRCP as fast as possible. But my idea of doing it as fast as possible is to get the exam out of the way, so that you can spend the next 3-4 years enjoying yourself, learning instead of studying for the exams and trying to cram for the exams. So I think if you're unsure what to do, why not you do your housemanship? And then you might find that, what, I have always wanted to be an O&G specialist, but what, turns out that I just end up being a pediatrician or something like that. So I think the journey is important. Look at it as marriage. You don't rush into a marriage with a girl, isn't it? Yeah, she looks hot, that sort of thing. But maybe she digs her nose at every time she wakes up the first thing in the morning, and then you don't want to discover this after the wedding, right? After the wedding, sign all the papers already, la 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 la. Next morning you wake up, you see her already sitting up there digging her nose. It's like, oh man, had I known earlier, I wouldn't marry her, right? Who would marry a girl who's digging her nose first thing in the morning, right? And then she roll it on the board and flick it off the bed. It's like, so think of it as marriage. You want to marry the perfect girl. You have to say to yourself, hey, I'm happy living with this person for the next 30, 40 years. In fact, if you marry a girl, you can divorce her and marry another one. But if let's say you want to say, oh, you become an internal medicine specialist, now I want to be a surgeon. You want to change specialty. It's more difficult than getting a divorce and marrying again. Put it this way, lah. So I think you want to go in something, you look, you don't jump into a marriage with someone. So take your time to get to know the specialty, work in it first. That's why people go dating, right? Go on a few dates, like, yeah, she's so stingy one. Always expect me to pay, yeah, don't want lah. That's all thing, yeah.
Okay. Yeah, doctor. So this is another question. Are we allowed to finish our MRCP during our housemanship, since there's a minimum? So how about the criteria? Because there is.
I think the Royal College has loosened. It used to be that you had to be 1 year working experience before you the thing, but now as long as you started working already, you can sign up for the paper, because the Royal College realized you sit for the paper, you don't have enough experience, you fail it, you have to sit for it again, and you're giving me another round of money. I make a lot of money from this. It's like, why do I want to limit your number of tries, right? Please take as many tries as you like, fail as many times as you like. The Royal College only gets a fat purse, and then so you are allowed to finish your housemanship. But for Malaysia, becoming registered with the NSR, you must. So you finish your MRCP, you have to have your 3 years, and then you do your 18 months. Then only you can register with NSR. So it doesn't matter if you finish your MRCP. But 10 years ago, 12 years ago, the moment they finish, they can start their exam straight. So it's a different time. So that's why you have people who complete 10, 12 years ago. You have people who completed their subspecialty training at the age of 30, 31. And that's all thing lah. Yeah.
Yeah, just like don't be 3K lah. Kiasu, Kiabo, and Kiasi. So everything need to be ASAP. So yeah, doctor, another question. What is the difference between MRCP and FRCP?
MRCP is lower rank than FRCP. You're a member of the Royal College of Physicians, but after 5 years of being a member of the Royal College of Physicians, you publish a few papers. Okay, you usually in the UK you finish your subspecialty training, then you can apply for your FRCP. The other difference between MRCP and FRCP is MRCP actually, technically, all these titles, if you don't pay the annual subscription, you're not allowed to use it. So there are a lot of people who pass the exam already, then they don't pay the annual subscription. So technically, they can't use it. The the annual subscription for FRCP is way more expensive than MRCP. So there are some people who remain MRCP the rest of their lives because they don't want to give extra money to the Royal College of Physicians. Yeah.
So, yeah. So, would Dr. Tan like to motivate or dismotivate us as to pursue internal medicine in the future?
Wait, I think there's a few questions that can I answer those questions first? Then,
Sure.
yeah,
Which question?
does research experience publication matter in master's application? Yeah. I don't think it matters. Do you see the one is below? Yeah. It does not matter. Okay, they don't expect you to publish. For the set criteria for master's application is SKT more than 85% 3 years in a row. If you want subspecialty training, if you have a publication and all, then it helps you lah. But then again, yeah. So there's a Dr. C here. May I know what is FRCP? Is it a form of subspecialty? No, it's not a form of subspecialty. Usually people have completed their subspecialty, apply FRCP. FRCP is just a title the college gives you. So basically it's like now you have the right to pay me more money for your annual subscription. Whether you are MRCP or FRCP doesn't make a difference. So a lot of people actually don't pay their annual subscription. They are still an internal medicine specialist recognized in Malaysia. Yeah. Doctor, then the one above it, may I know if MRCP will still be recognized as a parallel pathway to come in another few years? Ha ha ha. Like I said, they're changing the rules every few years. I don't know. Okay, what was applicable last year? That's why sometimes I know people like all these kind of talks, they enjoy, tell a few jokes, listen. But you see, what I tell you tonight, suddenly next month they might put out a new ruling and then suddenly everything is not applicable already. Suddenly they can, but the only thing is, the MRCP people are very powerful in Malaysia because so if you say that I don't recognize MRCP anymore, I only recognize masters, it's tantamount to saying that their qualification is not good enough. Okay, I think like 60-70% of the subspecialists and profs in this country are MRCP holders. So unless you want to fight with them, I don't think anyone will be de-recognizing the MRCP anytime soon lah. But I guess medicine is actually it's not just head knowledge. A lot of people think I passed my part 1, part 2, I'm very smart. But a lot of it is actually practical experience. And also, like you said earlier, it's an art. So the art only comes with heart, comes with empathy. And some of these things can be taught, some of these things cannot be taught. You just have to live it and experience, make a few very bad mistakes, embarrass yourself in front of people, or get screamed at by some relatives because of the way you speak they find it arrogant, or you find and then you learn how not to talk in this way and how to control your face and all that sort of thing. Yeah. Above it, what's the best branching to go in for internal medicine? Special features need for certain branches. I tell you what, that's one thing I like about Masters of Medicine, because you actually go through all the subspecialty, and then you can actually have experience of one. For example, cardiology have really, really long clinics. So do you like that? Rheumatology had only 2 short clinics a week, so something like that. Better quality. So if let's say I'm not being sexist here, but if let's say you are a girl and you're interested in starting a big family, 4, 5 kids, cardiology may not be for you. Okay, but and then you might want something like dermatology or something, so you can go home and cook for your kids or pick your kids up from school. Yeah. So it's up to different people, different. So I think you have to do the rotations, then you realize what you like. Another thing is do the rotations, you meet all the different kind of people. So it's like you're like, oh, cardiologists are all like that one. I don't think I can work 20, 30 years with this kind of people. Then maybe cardiology is not for you. Because to a certain extent, unfortunately, a lot of even if you talk about specialties, orthopedics, there are now more females in orthopedics than ever before, but it's still a big boys club sort of thing with all this, doing the guys thing, driving cars up the hill, doing this kind of things, telling all sorts of inappropriate jokes in the OT, that sort of thing. So yeah, so you have to can I live with this? Will I get offended by the jokes they tell? It's like so depending. So I think there's I think we are achieving parity, gender equality in most of the specialties, but I think certain specialties still are very much male dominated. Yeah, because for example, cardiology, you get pregnant, how are you gonna go and you are exposed to a lot of radiation, so you might like, I don't want to affect my baby, then you cannot be as aggressive as the guy to do all his procedures. So you probably do more procedures, get more experience than you. You may be the better person to interpret ECG and doing echoes, but he do more procedures, so you look better in the eyes of the bosses than you. Yeah. Incidentally, like Maria Scabosa, Scabosa criteria for ST elevation MI in patients with left brain is a female. So females actually do very well as cardiologists. In fact, I think they will make better cardiologists than a lot of males. But it's just that sometimes, biologically, it's like, oh, I want to have children. Then you're like, oh, I'm pregnant. It's like, then you might not be as aggressive going in. So there are all these small things that unless you're in there, then only you notice. It's like, yeah, maybe it's not for me lah. So not to discourage you. If you're a girl, you want to achieve the thing. You're not planning. You see, if you're just planning to have one kid, then yeah, go in and do as many cardiology procedures as you like. Yeah.
So doctor, another question. HLP same as master. HLP is just somehow the scholarship.
Yeah, the Hadiah Latihan Persekutuan. That is the money from KKM that will pay your salary for the next 3-4 years. Yeah.
Okay, so interesting. So I also aware that Dr. Tan has his own blog. I mean, there's a website sharing some interesting music. Nice read up just now. I have read out some of the story. So yeah, so Dr. Tan, would you like to share how you read?
That's why if let's say you are aiming to finish your MRCP as fast as possible and you're trying to do Kuma and Clark twice within a year, I don't think you have very much time to read anything else, okay? So if you decide not to sprint to the finish line, you decide to take a slow walk, enjoy the sunsets, stop by the roses and smell it, then you have more time to do other things. Of course, I'm a very privileged person. I was given the opportunity to study music when I was younger, so I did my grades in piano. And then in piano music, one of the things you have to learn about is the Western culture. So you have to learn about the Renaissance music and Renaissance classical music, Baroque period, classical period, Romantic, modern music. So, and because you learn about the music, then you realize that all of art is interconnected. So you also have to know a bit about how the architecture is affected by the music, how the music affects the architecture, and how it affects painting, dance, theater, literature. Our influence music. So you end up reading a lot of things, read widely, and then that's it lah. And then a lot of people. I know a lot of people, they like Twitter. They like to read all these political blogs, and then people arguing. But actually, wow, they're arguing over the same thing over and again. You don't know. People read about what US politics and it's like, it's the same thing over and over. They're all shouting, screaming over the same thing. I prefer, read about poetry. I also like to study history. History will tell us a lot about what has happened in the past. People think about, husband nowadays, kids nowadays, so ill-disciplined. Yeah, you know what? They were complaining about this since 400 BC. People are talking about children nowadays are so soft compared to their ancestors. Yeah, it's been on since it's the same thing that on you go and check the codes, they've been on around for 2,400 years. The old generation complaining about the new generation. Yeah.
Okay, thanks, doctor. Yeah, and what updates about the National Postgrad Medical Curriculum?
Actually, I don't have it. I sit next to my roommate is Dr. Lam, the palliative care physician. So he's actually on the committee. I think they are reaching towards the end, but it hasn't been finalized yet. So, and then with this COVID and all, I think everything is put in the banner. But hopefully, I think they are doing really, really good work. I think they want to standardize the curriculum, and they want to get the MRCP people to also get the same amount of experience as the people in their master's program. And also, because sometimes it's like, you get to go into master's, you got to their masters, they are the in-campus and off-campus. In-campus are the ones who do all their 4 years in University Malaya. The off-campus, first 2 years in their old hospital and then 2 years only. So then there's sometimes a bit discrepancy because the hospital you're in don't have all the subs, so you have only limited experience here and there. So if let's say hopefully with this national curriculum, everything will be standardized throughout the whole country, everyone is supposed to teach that, if let's say the guy from KKM first 2 years come in, they should know this, so that at least there's some standardization. If not, people in the KKM is like, you are there for service, you're there to work only. I don't care whether you learn anything or not. You learn whatever you can pick up, but read on your own but other than that, nobody teaches anything. So not 100% true. I know in KKM some people love to teach. Can also be said about in University Malaya. Some people don't like to teach, but by the end of the day, we have to look the long view. We want at the end of the day, you guys are going to be the physicians of the future. You guys are to be the ones that are going to send out, and you guys are the ones that are going to bring up the healthcare of this nation. If we want to reduce the number of infant mortality, we want to reduce the number of unnecessary myocardial infarction deaths. Everyone it's all hands on deck. You have to train enough cardiologists. You have to train enough gastroenterologists. I know that we all like to make fun of gastroenterologists and cardiologists, but at the end of the day, if you want to, in Japan, they are very aggressive OGDS screening for gastric CA, and they pick up gastric CA very, very early. And you can't do it in Malaysia because there are only so few gastroenterologists. And if you say, okay, all Chinese male above 60 must get an OGDS every 2 or 3 years, I tell you, we will not be able to finish it. It's like 10 years or so, we haven't finished the first round yet. So if we want to improve our country, we want to develop our country, okay, we had to reach the point where we have enough cardiologists and everyone is within like half an hour from a cardiology center, chest pain, straight away go to the nurse hospital, we'll go in and do the PCI for you. Yeah, at our current numbers, we can't do this. We can't reach international standards. We can't reach standards of care. We can only reach it if we have enough people, and we have to fight for that. Yeah.
Okay, doctor. Yeah. So, from Raymond, so how do you predict COVID-19 will change the way internal medicine training is done in Malaysia?
Okay, you know what? This is looking to the future. I'm not very good at predicting the future. But I can tell you what. If you or anyone of you born in the 80s, all of you are born in the 90s, right? Okay, sure. Okay, I'm born in the 80s. I'm an old man. So I still remember in the GP clinic when I was a kid, 4 years old, like that. When I go into the GP clinic, they used to all the tongue depressors used to be made of metal. A lot of the stuff were all metal, and then they were soaked in a gigantic alcohol pot. And then insulin used to be administered in big needles, so people has glass syringe with big needles, and then they put in the needle, and after that they remove, and then they soak the thing into the alcohol until the next use. So that used to be, and if you see some of the old surgeons, they don't like to wear gloves on. Okay, then AIDS epidemic happened. Okay, HIV happened. Then you don't know. At first, when it come out, everyone's scared to even touch. You got HIV, I don't want to even touch you. You use the spoon already, I throw the spoon away. Yeah, so because there was so much ignorance about the HIV and AIDS, of course, now you look back, now it's like almost 35 years later, you look back, oh, why people so primitive? Yeah, we are behaving with the same primitive way toward people with COVID-19 because we don't know what is going on. But after that, everything become disposable needles, disposable syringe, disposable gloves, everything where people wear double gloves, triple gloves. Yeah. So because of the AIDS epidemic, it changed the way we practice medicine. COVID-19, how will change medicine? Look, if you sit around some of the old doctors, they say, oh, I had very bad diarrhea, I still come to work, I go and see the patient, then I go to the toilet, then after I finish pangsai, wash, and I come back and continue seeing the patient. I didn't even take a day off in my whole life. There are some people that used to be like, oh, then people like, oh, we don't take MC, houseman nowadays, oh, sikit sudah ambil MC, But now with COVID-19 and all, it's like, oh no, you are runny nose, please don't come to hospital, you might infect everyone on the team. Go home. So it has totally changed our attitudes towards taking MCs. I think we used to be like, Okay lah, we are a bit Neanderthal about taking MCs. Only the weak take MCs. But now I think for the sake of the team, please don't knock out the whole team. If you feel sick, just don't come at all. So the attitude towards people taking MC has changed. So I'm sure there will be other changes and things that happen lah. Yeah.
So, Doctor, another question regarding pursuing a career in sports medicine. So, what is the probability to pursue master program?
Okay, to be honest, I'm not in the. It's not my specialty. I mean, internal medicine is It's like, so I can't give you anything. But I guess interest is everything, and I think sports medicine is just something new that's just developing. So I don't think that their program is that massive and they have that many people. So chances of getting in, but I think it's the interest. From what I know about the people who do sports medicine and all, a lot of them, they are athletes themselves. They play a lot of sports. They get involved in a lot of these sporting activities. So they are doctors for sports teams and all that sort of thing. So they start from the beginning in this thing. So I guess interest and the thing lah. But I cannot comment any further. Yeah.
So I think the last two questions for Doctor. So do you think, work-life balance and perhaps the income?
Okay, I think in terms of income, how to put it? Look, the problem with okay, how should I approach this? Income, work-life balance. Let's do income first lah. All right. 20 years ago, if you are an internal medicine specialist and then you start specialize in cardiology, and then within 1-2 years you leave and go into private practice, you'll be rich. You'll be living in a house in bungalow in Bangsa with a the Mercedes will be your cheapluck car. You actually have a Lamborghini, you'll be very, very rich. In fact, you don't even need 20 years ago, 30 years ago, you don't even need to specialize. You just go out as a GP also, you can make very good, comfortable living. But as the number of people the number of doctors increase, because doctors don't die, they don't retire at the age of 55. A lot of them work on, I heard of doctors who work on until the age of 85. Okay, they still see patients. So basically every year the number of doctors are increasing. So they are like, so if I got so many people to choose from, why would I'll choose the guy who either give me very cheap rate or who's very, very famous. For example, Prof. KL Go retired 2 years ago. So when he went and opened his own private gastro clinic, I heard he was only charging like $100 per session for a consultation session. So people are saying, look, for $100, I cannot go and see Prof. KL Go. Why should I pay 150 to see you who learn under him? So basically, between him and Prof. Alex Liao, Prof. Alex went to Pantai, Prof. KL Go went to Sengil. If you go to Bangsa South, you'll see his clinic there. So basically, they suck the oxygen out for Klang Valley. So if you want to compete with them in Klang Valley, cannot what? So in the end, you're forced to go to a small town and all. But going to a small town is actually not a bad thing. I think Taiping is a great place to retire to. Taiping is a great place to raise your kids. So I think in terms of money, you won't be rich lah. If you're talking about making as much money doing a subspecialty and then leave for private as far as possible, because every year the number of subspecialists that go private is increasing. So everyone also wants to be in Klang Valley. So unless you're willing to move out of Klang Valley, you are not going to survive. And with the COVID-19 now, everyone is scared to go to a hospital, and also businesses is really suffering. So yeah, internal medicine can give you a good life. It depends on how the powers that be. I cannot predict who will be the head of service, who would be the thing. For now, like for now in Masters of Medicine, a lot of the rules were set in the 70s and 80s. So basically, if let's say you get pregnant and then you deliver, okay, if you take longer than in that every semester you are allowed to take your exam. So if let's say you're supposed to take your exam in April, okay, and then in January you delivered. So if you take your full maternity leave, 2 months, you cannot go and sit for the paper because they say you have missed too many days already. So a lot of them will deliver in January. After 2 weeks, they'll come back from they basically don't have a maternity leave. 2 weeks after delivering, they come back and they're back to work already. Yeah. So imagine we do not have maternity leave for people who are taking Masters of Medicine, because if you take your maternity leave, sorry, you have to take you are deferred 6 months, you have to take an exam later. Yeah. So a lot of people is like, so they have to choose. We make women, imagine we have to make women choose between their career and their children. It's not fair. If let's say you have the knowledge, you should be allowed to take your exams. Allow them to take the exams, and then after that, if you feel that okay, you know what, they are supposed to replace the 2 3 months, then let them replace the 2 3 months. Because if you delay them taking the exam, that means they can only take it in October. That means they already lose the seniority, because a lot of times they already study for it. They can pass it. You just give me the opportunity to sit for the paper. No, 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 no. You cannot. Why can't they just sit for the exam and after that go and replace the paper, replace the time period that they miss? No, they cannot. If you miss it, you have to take it the next time. So there's still a lot of these arcade rules that people like Dr. Lam is trying to change that. But of course, you still have all these dinosaurs up there in the system and all, and they don't want. Oh, we shouldn't change these rules. Like, yeah, because you're not a woman, you don't know how is it that you have to leave your kid after 2 weeks of delivery and then come back to work. It's like we have all this nonsense that's still ongoing. So until somebody at the head of service was like, look, this is nonsense. This day and age we are forcing women to come back 2 weeks after delivering. This is barbaric. We should say, okay, fine, you can still sit for the exam, replace the time period or something like that. So give you a good life in the future. I don't know. I cannot predict who will be the next head of service. I cannot predict who will be the next dean or prof and all that sort of thing, because a lot of these things are in KKM's hands. So UM will say that, you know what, we should be letting people take their maternity leave and still let them sit for their papers. That's my personal view. But other people say no, then like what to do? Yeah.
So top of the pyramid that decide the future of it.
Yeah. But we be the change that we want. So hopefully, one of these days, maybe not this generation, but in the future, maybe your kids, when they get pregnant, they don't have to come back after 2 months. They can still sit for the paper in April and then just replace it after they have completed pass the paper lah. Just it's that easy. I don't see why they can't do it. I don't. There's a lot of things I don't understand.
Okay, and the last words from doctor for this session. So yeah, any motivation for us, or like some words of wisdom for us?
Words of wisdom. Actually, to be honest, I'm not a very wise person. If you actually know me personally, you know that I'm a very flawed person. I got a lot of weaknesses. But I think it's very important to enjoy the journey and not to rush through things, and just I want to finish as soon as possible, come out and go into private practice. Yeah. Because in the future, people will be looking at people are like, look, you are so young, just become a subspecialist. I can look 10 years from now, Prof. Kiago is probably still gonna do scopes. Okay, his father is 88 years old and still young and still very healthy, driving himself around. So if the genes pass on in his family, I can assure you, 85 years old Prof. Kiago is probably still doing scopes. And I don't think he plans to retire. So if you finish everything as soon as possible and go into private practice, you think you'll be making millions? Like, no, you'll be competing with Prof. LXL, Prof. Kiago. It's like, ha, 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 ha. Your dreams of making millions is gone. Yeah. So the other thing is enjoy the trip. I think you may also, I think the other thing I want to encourage is look at out of the box, because everyone's like, I want to be a cardiologist, I want to be a gastroenterologist, I want to be this. But everyone is doing it. You are what's so special? What is your niche? But I think there's a lot of subspecialty that you can bring in. So if let's say you become an internal medicine specialist, you might consider go to UK, not to go and contribute to people who are already developed country, but go and learn internal medicine. You can become an immunologist. We don't have an immunologist we have one or two in Malaysia, but they are not in the government sector. They all went private already. There's no sleep medicine specialist. So in the US, sleep medicine is actually a branch of internal medicine. We do not have a allergy specialist. So you in the US is allergy and immunology. So you can be one of those and can go to the US, study immunology, and you come back and you might be the only one in the whole country. What else? There's sleep medicine. There is wait, let me just go and check let's go and briefly check what other. Can't think of anything at the moment, but wait, just give me a sec. What other things? You can be allergy and immunologist. There is sleep medicine, rheumatology. So there are so many things. Hospital medicine. I think there's so many things that people can work in. In Mayo Clinic, they actually have a wellness center that actually, if let's say you want to lose weight, you check in 6 weeks with them and they help you lose weight. So there's actually a whole lot of things that you can do that is not done in Malaysia, but other people are doing it. If you go do your internal medicine paper, go overseas, go and learn it and bring it back, you know what? You get your work-life balance. You also get the money, but you just have to be out of the box and do something that's different from other people. Yeah. So find a niche. I think you read widely. You don't have to be the smartest. You don't have to be the best. But if you are doing something that nobody else has, I think sleep is becoming a problem among people. Oh yeah, we don't have a stop smoking clinic in UM. So if let's say you specialize in nicotine, of course I know addiction is usually under psychiatry, but psychiatry has a big stigma. You say I'm going to refer you to a psychiatrist for your smoking habit. It's like, I don't want to see a psychiatrist. I don't want to see. Other people think I'm crazy, and you have to take that into effect. So in UK and US, it is the internal medicine specialist that's helping with all this nicotine cessation. So if you learn one of those things and you bring back, and then there are millions of people in this country that in dire, you say cool, yeah, right. Doesn't happen one lah. You need someone to guide them. You need someone to counsel them. It has to be the right mental framework. There are drugs, there are nicotine patch that can help the person. You don't have to go. So if you learn all these things and you're like the first and best in the country doing this, then I'm sure you not only you benefit society, you'll also be rewarded with the things that you want, like your work-life balance and your money. So yeah, just don't do that. Or everyone else be in dermatology and all that sort of thing. Do something that no one else is doing. Yeah, and I think the country will be better and you'll be better off. Yeah.
Yeah, thanks for the inspiration. Instead of going overseas to serve their people, why not bring back something as the pioneer of that as their subspecialty in Malaysia.
Yeah, but you have to disappear for 2-3 years lah. But I think I think it's a trade off lah for our country. Our country, we are still a developing nation, and I hope that people won't just go to UK and just disappear forever in the UK. Yeah.
Doctor, this will be the last question. I think somehow they posted this, and yeah, I don't really understand what's the story behind this, but yeah, it will be interesting for me to know that.
I also don't know why they ask me how many ducks can you take on in a fair fight. Put it this way lah. I don't think I can. I think the ducks can beat me lah. Okay, they'll beat me. I don't think I can beat any of the ducks. Ducks can swim much better than me. So, yeah, I don't think 0-0. The number will be 0.
So, thanks, Dr. Tan, for your time, and it's really an inspirational moment for every one of us. And do share with a lot of with us regarding internal medicine, specialty in internal medicine. So, thanks, Dr. Tan, for the time. Would Dr. Tan like to give any last input or?
No, thank you for inviting me. It's an honor. I always felt it's an honor to be teaching in University Malaya, and I'm very grateful for that. And yeah, I hope that you all get something, and then you all pass on lah. Whatever I pass it on to you, of course, my knowledge will be outdated, but then you all will definitely do something greater than me, and hopefully one of you will win the Nobel Prize or something. Yeah.
Okay, thanks, Dr. Tan. So,
thank you.
This weekend, hopefully you can have a great weekend, rest well, and also the reason that Dr. Tan doesn't prepare a slide for this session will be as things will keep updating, and perhaps what Dr. Tan shared with us today might be outdated tomorrow if there's a new ruling. Yeah. Okay, thanks, Dr. Tan. So
thanks.
So to the audience, stay tuned. We will in future we will be having more specialty talk with different specialists. So I would like to end the broadcast here. Thanks for supporting. Okay.